Good evening, everyone. My name is Dr. Elaine Schulte. I'm the Vice Chair of Academic Affairs and Faculty Development at the Children's Hospital, and it's my pleasure to introduce you to our webinar speaker this evening, Dr. Molly Regelmann. Dr. Regelmann is an Associate Professor of Pediatrics at the Albert Einstein School of Medicine and has been a member of the faculty in the Division of Pediatric Endocrinology and Diabetes at CHAM since 2016. Dr. Regelmann received her medical degree at NYU School of Medicine. She completed her general pediatrics residency and pediatric endocrinology fellowship training at the Icahn School of Medicine at Mount Sinai. Dr. Regelmann is the Pediatric Endocrine Fellowship Program Director and a clinical general pediatric endocrinologist with expertise in growth disorders, disorders of puberty, adrenal insufficiency, thyroid disease, and diabetes. She also has a particular interest in caring for children and adolescents with rare disorders. She sees patients both at CHAM and in the Westchester Satellite Practice. She's an active member of the Pediatric Endocrine Society's Drugs and Therapeutics Committee and has been a leader in developing screening guidelines for adrenal insufficiency in boys diagnosed with adrenal leukodystrophy. Dr. Regelmann will speak to us today about a general approach to disorders of growth and short stature.
Thank you. So welcome, everyone. I am excited to talk to you about growth and short stature tonight. I have no financial disclosures, and I won't be talking about anything off-label. These are the objectives for tonight. I'm going to review some basics of growth monitoring and the normal variants of growth. I'm also going to go over how to recognize systemic diseases and medications that can lead to growth failure and understand how to manage those. I'm also going to go over endocrinopathies and causes that cause growth failure. And then at the end, I'm going to discuss the use of growth hormone and potential side effects. So I'm going to jump right into this. I know everyone here, I think, is a general pediatrician, so hopefully this is not so foreign, but it's important to start out the night by just saying height measurements are really important to be accurate. And under the age of 3, it's recommended that measurements of length are supine and then standing after the age of 3. And important to make sure that shoes and hats are removed, hair is down, and that you have the head at a 90-degree angle to the board, and that you have the head, shoulders, hips, and ankles back against the wall or the board. And to plot by year and months to the exact day. The nice thing about the electronic programs is that usually happens automatically for us. The electronic programs are great in that they automatically do pull up growth charts, but just important to make sure they're pulling up the right growth charts. For children under the age of 2, it's recommended to use the WHO growth charts. This recommendation was made about a decade ago, and the reason for this is the WHO growth charts include breastfed babies, whereas the older CDC growth charts that went from 0 to 36 months primarily had formula-fed babies, or at least the majority of them. The CDC growth charts are then recommended to be used between the ages of 2 and 19. And these data were collected between the years of 1963 and 1994. And I mention this because the data were collected prior to the onset of the obesity epidemic that we've been dealing with. We use EPIC at Montefiore, so I pulled out how these growth charts look in EPIC. These may look a little different if you're using other electronic systems. The other thing I want to point out is that there are disease-specific growth charts out there, Down syndrome being one of the more common and really more reliable ones. So making sure that everything matches for age, sex, and the disease that the child may have is important. This is the growth chart that I use all the time, which is a height velocity growth chart. I think this is the one that when most parents come in to see me, they're not used to looking at, and I have to orient them to how the chart looks. The y-axis includes the height velocity, and then the x-axis is age. The solid lines are the percentile lines for children who are going through puberty at an average time, with the black solid line being the 50th percentile. And then the dotted lines that you see on the growth charts represent +2 standard deviations and -2 standard deviations for onset of puberty and 50th percentiles for them. And I do like to point out that while most people like to say, oh, you need to grow 2 inches per year, particularly in the boys with late puberty, the average rate of growth drops down well below 2 inches per year. And if you sort of take and think of these in terms of percentiles, it's not unusual to have a boy with delayed puberty at the age of 12 or 13 who's growing at about 1.5 inches a year. And there are sex differences for puberty and growth. I stole the slide from my new division chief, Lori Cohen, just to point out that girls and boys are different. The onset of puberty, the pubertal peak rate of growth for girls is about 2 years earlier than average. And for anyone who has middle school children, and it's pretty easy to see this in the 6th and 7th grade, where girls often are taller than the boys. But there are wide variations in onset of puberty timing, and the tempo can vary quite a bit. And there's a lot of normal variation that doesn't really get reflected so much when you're just using the standard growth charts, which is why the height velocity charts, I think, are really helpful. So that's just for how to monitor. Now I want to move on to defining short stature as well as other growth variants and talk a little bit about how to go about evaluating them. And then we'll do some fun cases. So this is just a normogram that we see all the time, bell-shaped curve, and height is normally distributed, with short stature being defined as -2 standard deviations on this chart. And short stature is classically defined as more than 2 standard deviations below the mean, which is below the 3rd percentile for age and sex. There are other definitions out there. Some people will define it as being more than 2 standard deviations below a midparental target height. This will depend on the midparental target height being from parents with normal stature or normal growth patterns and not having pathology themselves. And then towards the end of the talk, we'll spend some time talking about idiopathic short stature, which is defined as more than 2.25 standard deviations below the mean, which translates to the 1.25 percentile. Most kids will find their height percentile that they're going to follow during childhood right around the age of 2. You can see it's normal for infants to cross growth percentile lines. After the age of 2 or 3, once they start having downward trends in percentile lines, that is concerning for growth failure and warrants evaluation. Another way of thinking about this is a height velocity that's below the 10th percentile will lead to downward crossing height percentiles as well. When you're measuring height velocity, you need at least a minimum of 3 months between measurements, but it's ideal to have more like 6 months between visits. And as I mentioned before, having a standardized way of measuring is really key. So not only having the kids stand in the same way, but having the same examiner, the same stadiometer can be helpful when you're trying to establish height velocities. So what are the things that influence growth? I like to say that there are 4 big categories of things that influence growth. And we'll spend a lot of time here talking about genetics. This includes midparental target height, chromosomes, genes that we think about. And then there's the category that I lumped together of all the things that you somewhat have control over, which includes nutrition, sleep, and exercise. I'm not going to spend as much time talking about these things today, but I think most of us are aware of how the impact of low calories or excessive exercise can affect growth. I've seen kids with really crazy abnormal sleep patterns where it's likely that their cortisol levels are influencing their growth because they're getting such little sleep at nighttime. And then systemic health is really important, and chronic disease will certainly lead to growth failure and needs to be considered. And then hormones, which are my favorite. We'll spend most of the time towards the end of the talk talking about growth hormone and the IGF-1 axis, but thyroid hormone isn't critical. Insulin, particularly in infancy, but also with obesity, can have a big influence. The sex steroids and pubertal timing play a huge role in timing of growth, and then glucocorticoids as well. So to talk about genetics, the mid-parental target height, I know in EPIC, you can just enter in the parents' heights and it spits out the height measurement or the mid-parental target for you. For those who do not have EPIC, the formula for mid-parental target is here. And for girls, it's about 2.5. It's the height is lower, and for boys it's higher. There are wide confidence intervals for mid-parental target, so it's not fair to say, oh, the child's parents are 50th percentile, therefore the height is expected to be 50th percentile. There's actually, it can really vary quite widely. And for boys, it's estimated that the intervals for mid-parental target are close to 4 inches, and that for girls, about 3.5 inches. There's also a tendency for regression towards the mean. So if you have parents who are exceptionally tall, like 95th percentile, they will be more likely to have children who are shorter than them than they would than parents who are closer to average would be more likely to have children who are closer to average height as well. There are now more than 12,000 described common variants in the genome that are associated independently with height and account for variations in height. So we do not go looking for all 12,000 variants, but it's just important to know that it's not a single gene for most kids that define their height. So whenever I see a kid who comes in for concerns about short stature or growth failure, I just do all the things that we normally do in pediatrics and start with the bread and butter, a very detailed history and physical exam. And when I'm taking a history, it's really important to get birth history. Children who are born small for gestational age, children who've had exposures in utero, have much different height trajectories often than children who did not. Girls who have swelling in their hands or feet in the newborn period are at higher risk for Turner syndrome, and asking about this sometimes can be helpful when you're trying to direct testing. Medical history is important if they have any chronic diseases. Also important to ask about history of head traumas, neurologic conditions, seizures. Medications that can potentially influence growth should be included as well. And then a really detailed review of systems can be helpful when trying to tease out causes for growth failure that do not seem obvious. When I'm taking family history, I include not only parents' heights, but also grandparents, aunts, uncles, and siblings' heights, and also the timing of puberty. Not unusual to have a boy in the office with delayed puberty who happens to have a maternal uncle who also was delayed in puberty, but the parents, mom and dad, both of that boy, both had normal timing of puberty as far as they recall. And this can be normal. And then when I'm doing my physical exam, I like to take additional measurements, including the head circumference, arm span, and I do a measurement of the upper to lower segment ratio. And then I try to take note of any dysmorphic features, looking for things like clinodactyly, limb length discrepancies, any facial dysmorphology as well. So when I mentioned the additional measurements that I take, head circumference, the Nellhouse head circumference charts can be used usually. And sometimes this can be a clue to a skeletal dysplasia. Similar, the arm span, a short arm span can also be a clue to a skeletal dysplasia, as well as an elevation in the upper to lower segment ratio. I put this chart in here just to point out that upper to lower segment ratios change with age. So as children get older, the ratios drop, and usually by about 10, the ratio is around 1. So if you have a 10-year-old with a ratio that's 1.3 or 1.4, that might point you more in the direction of looking for a skeletal problem. So what do we do in terms of screening? So after we've taken the detailed history and physical exam, if there's a condition that we're concerned about, we then go ahead and test for that particular condition. But if there's nothing that really is showing up as being a concern, and we have a child in front of us who's either not growing well, crossing percentiles, or has a height that's significantly below what's considered normal, below the 3rd percentile, then we do screening tests. And there's a consensus statement that suggests that all of these tests need to be done. I want to emphasize that I don't think that they all need to be done, particularly if there is a concern that you have found that points you in one direction or another. But screening for chronic inflammation, screening for renal problems, growth hormone is the IGF-1 and BP3, and IGF-BP3 really only needs to be done under the age of 3. Celiac, thyroid, and then a karyotype in any girl who has unexplained short stature, even without dysmorphology. Turner mosaicism is a common cause for short stature in girls. So what does all of this cost? And it costs quite a bit, actually. So a retrospective chart review was done at a large pediatric endocrine center about a decade ago now, looking at what the cost of all of these tests are. They looked at little over 1,300 patients who had been referred to their center for short stature. We'll talk about the exclusion criteria here in a second, but 235 met the criteria for idiopathic short stature, meaning their height was below the 3rd percentile. And in this case, they did not have clear height velocity deceleration. Their height velocities were steady, and their physical exams and histories did not point to one diagnosis. And so general screening was done, as I mentioned on that previous page. 64% had some of the recommended tests. Only 2% had all of the recommended tests. And when they totaled up the cost for those 235 patients, the cost of all the testing was over $300,000. And the result was that they found 3 out of 235 patients with a pathologic diagnosis. 2 of them had celiac, 1 confirmed by biopsy, the other not. And a 3rd had a very rare defect in the IGF-1 receptor, which actually does not have a treatment. And so the cost per patient diagnosis was over $100,000. I also just want to point out all of the patients who were excluded. Over 50% of the patients had heights that were considered in the normal range. A small percentage had true frank growth failure. And then about a 3rd had symptoms or concerns that led to a diagnosis for them. In the other group who had short stature and had normal testing, about a 3rd ended up being defined as having idiopathic short stature. Just under half had constitutional delay, and then a smaller percentage had familial short stature. So it definitely costs a lot what we do. And then I'm going to add one more test in here that I just want to discuss a little bit, which is the bone age test. And it's something that we often ask for in pediatric endocrinology. And I think that we kind of keep it as a little bit of a mystery what it is. So it's a picture of the left hand and wrist. And we traditionally use a book from Greulich and Pyle, and I put it right next to me. It's usually with me at all times because I use it quite a bit. There are a lot of problems with the data that we have in this book, but it's kind of the best thing that we have right now. The data were all of the x-rays were done in cross-sectional fashion. So these children were not followed longitudinally. They were for children from central Ohio in the 1930s when nutrition was quite different, and it was primarily a Caucasian population. We know that obesity accelerates bone maturation, and we know that bone ages tend to be different depending on ethnic backgrounds. Again, it's the best that we have, but it is important to keep in mind that often in otherwise healthy kids, their bone ages may be a little bit older than their age, and that can be totally normal. On top of all of this, it's a really subjective test. It's really dependent on who's reading it. I always like to think that I'm somehow spectacular at reading these, but I know I'm not perfect. And the radiologists who read them, I'm sure, feel the same way as I do. There are now artificial intelligence programs that are being used to read bone ages, and hopefully this ultimately will reduce some of the variability in interpretations, but it can sometimes be alarming to parents when they have one person reading the bone age drastic, like a couple of years different than another person, but it really is like just comparing the pictures in the book to the picture of the child and their x-rays. So it's not unusual to see variations. Okay. So we'll spend the rest of the time going through patient presentations and applying all of these principles to them, because I think it really demonstrates what we see on a day-to-day basis. And we'll start out with our first patient here with a pretty typical growth chart. He's a 14-year-old boy. And I'll kind of answer the questions for us. So what do we want to know? We want to know a pretty detailed history, but I really want to know what's going on with his puberty. I want to know if he has other health conditions or medications that may be influencing either the growth or the pubertal timing. And then I also want to know what the mid-parental target heights are and what the family history is for this boy. As you can see, he started out like sort of around 5th to 10th percentile, and it's kind of drifting down a little bit here at 14 years of age. So when I take away my chart and I show you where his growth chart is, ultimately, this is a kid who has constitutional delay of growth and puberty. He's in really early puberty, right around 14. It's a normal variant of growth. Nothing needs to be done most of the time for children with constitutional delay. It's more common in boys. It's more common to have a family history of delayed puberty, but about 25% of kids with constitutional delay of growth and puberty have no known family history. If at 14, there are no signs of puberty starting, so no change in testicular volumes, we do sometimes consider a short course of low-dose monthly testosterone injections to try to induce puberty. But generally speaking, we don't need to do anything, and most kids will spontaneously go into puberty on their own. This is patient 2. His growth chart looks very similar. He's 12. Again, the same things I want to know. I want to know, is he in puberty? Is he on medications? Are there any other health conditions? And what about the family? And this chart is more of a typical chart for a kid who has familial short stature. The mid-parental target height is at the 5th percentile. Again, it's a normal variant. Even though he's probably hanging out at the 3rd percentile, this is within normal limits for the family. And with puberty timing that's close to average, there really is nothing that needs to be done. I will say it's not unusual to see both of these boys come into my practice. And it's not unusual that they have a lot of blood work or an hand x-ray done. And I'm supposed to be cost effective and tell everyone, don't do anything, just watch and monitor. I think it's really hard sometimes to do that with parents. I do my best to explain that I think it's healthy and that it's not needed, but it is difficult. And a lot of people want reassurance as well, which I can appreciate. A hand x-ray probably is the best way to reassure both of these families, and the familial short stature case, just to reassure that everything is normal and the bone age is on track and not remarkably advanced. All right, so those are two of the common normal variants of growth, and really nothing needs to be done other than reassurance and monitoring. The next patient is definitely not a normal variant of growth. This was a referral from a few years ago that I had. At the time, he was 12, and he had been seen by his pediatrician, and there were concerns for growth failure. His height had been hanging out right around 75th percentile. His mid-parental target was around the 90th percentile. And you can see that it had sort of gone off a little bit at 11, but by 12, it looked like he was shrinking. He probably wasn't shrinking, but probably had a little bit of an overestimate there. His weight had also dropped off pretty dramatically as well. So in this case, I took a pretty detailed history. He had a medical history of asthma and multiple food allergies, including a dairy allergy, and was not drinking milk regularly, but was on supplements. His medication list included Montelukast, fluticasone, and levoalbuterol for the asthma. And on review of systems, he wasn't eating so well. And his psych history was remarkable. That mom was like, he's just sad all the time. When I did his physical exam, really nothing stood out particularly, other than he was a little thin. And he did not have a particularly Cushingoid appearance. And he was actually in early puberty, so making me even more concerned that that growth chart was not reflecting a normal growth pattern. And I did screening tests. I happened to be seeing him in the afternoon, and I had a suspicion for either a pituitary, I had a suspicion for an underlying endocrine concern, given how dramatic the height velocity had gone off. And I did an afternoon cortisol, and the reason for that was because he was using fluticasone, and I know fluticasone can suppress the adrenal axis. I also did other screening tests, all the other basic screening tests, and probably, again, a little bit of overkill, but thyroid, typically, classically, kids are gaining weight when they have hypothyroidism or growth hormone deficiency. But again, this was a pretty dramatic growth chart, and I wanted to make sure I wasn't missing anything. Celiac disease and IBD certainly can present like this as well. But what was most remarkable was that the cortisol was low, and then DHEA sulfate, one of the adrenal hormones, was also remarkably low, particularly since it seemed like he was starting puberty. And he had a delayed bone age as well. So the low cortisol was a reflection of adrenal suppression, and we confirmed that it was from fluticasone. And this is the part of the meeting that if we're in live person, usually I see people getting palpitations and nervous, like, oh my gosh, I prescribed so much fluticasone. What is this? But it's a really rare side effect of fluticasone to see this degree of growth failure. But the nice thing is after consultation with his pulmonologist, he was switched over to a different inhaled corticosteroid, and he had a beautiful acceleration in his height velocity and recovery of his adrenal axis. And this is the growth chart through the last time I saw him. His mom actually sent me a message last spring when he was graduating from high school and said he's over 6 feet tall and he's a happy kid. That sad mood seemed to go away when the fluticasone went away. And so the thought is the fluticasone was being systemically absorbed. And this is even though classically we think of steroids causing weight gain, the kids with fluticasone, particularly, and I'm saying fluticasone, but any of the inhaled corticosteroids, or some of the topicals or eye drops that ultimately lead to growth failure, tend to often not have the excessive weight gain that goes along with it. And there are different theories about it, but it seems like they kind of have a decreased appetite, that it's like enough steroid is absorbed to suppress their growth, but not enough to really stimulate the appetite. And they kind of have this adrenal insufficiency picture as well, where they're not as hungry. So the Pediatric Endocrine Society recognized that this was something that does periodically come up and probably is not so well recognized, and actually put out a statement a few years ago, which was a review of what's in the literature and also recommendations for monitoring kids who do need to be on steroids, including inhaled corticosteroids. And they've commented that it really is a minor risk to growth, and that the respiratory benefits far outweigh that minor risk to growth. So you can all take a sigh of relief that it is a good idea to be treating your kids with asthma with these for sure. But they did comment that you do need to monitor kids who are on the inhaled corticosteroids, because particularly those who are on higher doses, are at higher risk for developing growth failure. Most are not going to have as dramatic of a picture as my patient, but it certainly can develop. And the nice thing is that most of the time, if one of the inhaled corticosteroids is causing the growth failure, most kids are able to switch over to a different one. In terms of less dramatic growth problems, the New England Journal published a paper a little over a decade ago now, looking at adult height measurements in a group of kids who were treated with inhaled budesonide compared to those who were not treated. And when they looked at their adult heights, there was a difference of about a half an inch in those who were treated with the budesonide versus those who were not. And it seemed like the loss in height happened in the prepubertal age group and in the first couple of years on treatment, but it wasn't cumulative. So it was like they lost that little bit of height, but then they never caught up, but they also didn't continue to lose height, which I think also is reassuring. And I think it's really important to control asthma. So I don't want anyone to take away to stop doing inhaled corticosteroids from that story. All right, and we'll move on to patient number 4. This is a different kind of pattern of growth, but also somewhat similar, just a very gradual deceleration in height velocity, as well as a deceleration in weight gain as well. And other than this 8-year-old point, generally had been kind of falling off both weight and height curves for this young lady. I saw her as a second opinion at 10 years of age. The history at that time was that she had started breast development around 9.5. She had an unremarkable birth history and developmental history. She had a history of allergic rhinitis and eczema, as well as this growth failure. She was taking allergy medications and a vitamin D and calcium supplement and multivitamin. So really nothing remarkable other than that growth chart showing both the deceleration in height and weight. Her review systems was also pretty unremarkable. Normal sleep and energy levels. Mom said, yeah, she's not the biggest eater, but she seems to eat a balanced diet. She loves carbs. What kid doesn't? No GI complaints, no history of head trauma, basically nothing on the review. Family history, everyone's heights in the family right around 25th percentile. There was an aunt who had early puberty and was closer to the 5th percentile, and another aunt at the 3rd percentile. No one with a history of autoimmunity or endocrine problems. I saw her at 10 years of age, and at that point, her height and weight had gone down to the 2nd percentile, and she'd started out closer to 10th percentile, so it was a little down, but nothing dramatic. She didn't seem to have any dysmorphology. She was in early puberty. Thyroid was fine. Her abdomen was fine also. I put in her previous testing, and also just to highlight again how much of a problem the bone ages are. This family was really worried about the and when you talk to the mom, she was really worried that the radiologist had read the bone age as advanced when she was 9 years old. And then, 9 months later, the bone age was now younger than her age, and bone ages don't go in that direction. They don't go backwards, but it just shows like how much variability, depending on who's reading the x-rays, is there. And then general screening tests had been done for this child. She had a normal karyotype. A SHOX gene mutation analysis was done. SHOX gene is the gene that's thought to cause short stature and Turner syndrome. It's on this pseudo-autosomal portion of the sex chromosomes X and Y. Both were normal. She had a pretty remarkably elevated SED rate, and her IGF-1 and BP3 levels were at the lower end of normal. The first endocrinologist went ahead and did a growth hormone stimulation test that was interpreted to be deficient. Her growth hormone peak was 4.7. Normal peaks are defined in the US as above 10 or higher. A lot of people will argue that 7 or higher is really preferred, but 10 or higher is as it is now. And then the repeat IGF-1 and IGF-BP3 were now below the reference range. And the sedimentation rate was still mildly elevated. And I think, I never spoke to the first endocrinologist, but I think the sedimentation rate was bothering them a bit because they did repeat it a few times. And a couple of times later, the SED rate was still remarkably high. And the MRI showed a normal pituitary gland. So then, because the sedimentation rate was high, the family went and had infectious disease and rheumatology testing, all of which was negative. And then they came to me as a second opinion because they really wanted to start growth hormone and they were concerned about it. And so when I saw her, I at the time, this is before we had stool calprotectin testing, I think I would have, if it were 2023, I would have sent a stool calprotectin because of this persistently elevated SED rate and the poor weight gain along with the poor height gain. But at the time, I didn't have it, so I sent her to GI, and an endoscopy was done pretty quickly thereafter and confirmed Crohn's disease. And in retrospect, this kid had a lot of stomach aches. When she started treatment, she was like, oh, I had no idea my stomach hurt. She had been living with this probably for years. So why was her growth hormone peak low? And why was her IGF-1 level low? So I want to start with growth hormone stimulation testing. Growth hormone stimulation tests have a lot of false positives. In research settings, with two stimulants being used, it's reported that 1 in 5, or about 20% of kids who are otherwise healthy, will test as though they're deficient. Children who are obese will almost always have a deficient growth hormone peak, so obesity will blunt the growth hormone response to the stimulants. And if children are not fasting, even if they have like a little mint before they come in to have the test done, that can suppress the growth hormone and cause problems. On top of that, the test has to be done perfectly. And even with all of that said, again, 20% of the time, you're going to have false positives. So going into stimulation testing, you have to really have a high suspicion for it because of the high false positives. And in the setting of inflammation, you're going to get low IGF-1 levels, not because you have low growth hormone secretion. In fact, growth hormone probably is secreted a little better in the setting of inflammation. What happens is the cytokines interrupt the production of IGF-1. This is a complicated chart, and the point of it is that growth hormone acts on its receptor. You have a whole series of steps to get to the production of IGF-1, and that IGF-1 then binds to its receptor at the epiphyses and leads to growth. And all of these little red negative marks are representing the cytokines interfering with that cascade. So with Crohn's disease, growth hormone treatment's quite controversial. There are a couple of small studies that I every once in a while have a parent come in and try to quote and tell me that this is going to help with the growth. But I will tell you the growth improves when the chronic inflammation is resolved, and the best treatment is treating the underlying inflammation. A lot of those small studies that parents like to quote are confounded by the fact that the Crohn's was actually being treated, and the benefits in height velocity tend to be very minimal and very short-lived when they do treat with growth hormone. And this is that patient after Remicade therapy and no growth hormone at all. And you can see what a beautiful acceleration she had. And she caught up on her growth chart. She ended up around 5th percentile, which is a little bit short for her family, but totally normal in the end. Okay, I'm sorry, I missed a chat question earlier, and I do want to go back and just answer it from, there was a question in the chat just about fluticasone, and does it cause suppression both of nasal and oral inhaled? And I would say yes. In fact, pretty much any glucocorticoid given in any form can cause suppression of the hypothalamic pituitary adrenal axis. I think that there are a couple of the newer ones that have not yet been described, but I'm not sure that that means that they're safer. It just may be that these are really rare presentations, what I just showed you, and that it just may be that it hasn't been reported yet. But you can definitely see adrenal suppression from topicals and from eye drops, inhaled, nasal. Can I comment on usual time used to cause problem? I would say that usually you can see the growth failure develop within a few months. So again, if you're doing a height velocity on the kiddo, most kids with asthma, you're going to see back in the office every probably 3 to 4 months. When you're starting them on new medications, you'll want to see them for follow-up. I would just say that's when it's important, if you know you're starting them on medication, to have a good height measurement, and then have a good height measurement at least 3 months later to see the height deceleration. And if you see the height deceleration, then a morning cortisol level can help you determine if you have adrenal suppression. I hope that answers the question. All right. I have 2 more endocrine patients I want to go over. So this patient presented with growth failure and height, but her weight was going up nice and steadily. And so you see the BMI rising. At 8 years of age, she was noted to have that significant growth failure. Interestingly, she had been diagnosed as having autism at 4 years of age, no history of head traumas, neurologic conditions, and her mom described her as always tired and kind of a lazy kid. There wasn't a family history of endocrine problems or autoimmune disease. There were several family members with obesity, type 2 diabetes, cardiovascular disease. And I do have permission to use this picture. This is a picture of the child about 3 months prior to diagnosis. You're going to notice that there's a central adiposity and a roundness to her face. Her height was significantly low. It was minus 2.67 standard deviations. She didn't have striae. She didn't really have hair changes, normal carrying angle, and her thyroid was only mildly enlarged. So she really has that classic growth pattern of an endocrine condition, the most common of which is going to be hypothyroidism. Growth hormone deficiency is still pretty rare. It's estimated to be about 1 in 20,000, and Cushing's disease is even rarer. That's about 1 in 100 to 1 to 100,000 to 1 in about a million or so. It gets a little more common as you get older for Cushing's. Same with hypothyroidism. This child had the most common of the endocrinopathies. She had a pretty significant hypothyroidism. The TSH was 287, and this was classic Hashimoto's thyroiditis. She was started on treatment with levothyroxine. I always like to just remind everyone it's a very picky medicine. It does not like to be co-administered with iron or calcium or fiber supplements or soy. So please, if you have patients on it, remember to remind patients not to mix the medicine. I try to remind them as well. And when you have such profound hypothyroidism and you start levothyroxine, there is a risk of pseudotumor cerebrae that patients you should be aware of as a general pediatrician, that they may call in with severe headache. It usually happens within the first few weeks of treatment. And what did I tell this mom to expect for growth? So we did do a bone age, which usually is pretty delayed with hypothyroidism that's this profound. And I told her to expect that the bone ages will start catching up, but that also the child's going to start having some acceleration in her height velocity. At 8 years of age in a girl, it's not unusual to see puberty start. Fortunately for her, it did not start so quickly, but her bone age did start to catch up quite a bit pretty quick. You can see that she had a beautiful acceleration in her height velocity. 9 months after starting treatment, she looks like a completely different child. This is the same amusement park, just 9 months after starting treatment in a year apart. And you can see that the BMI drastically improved for her too. So BMI was going up, and there was a family history, and I think everyone kind of was like, oh, everyone's overweight in the family, but really that height velocity was important for her. And then my last patient is one of my favorites. She was 13 at the time I saw her for her first visit. She was 13 and a half months old and had severe postnatal growth failure. Her only other history was congenital hip dysplasia. Birth history was pretty unremarkable. She was a little borderline small at birth, but nothing dramatic. She was just taking Tribisol. And developmentally, she was doing fine in terms of language and fine motor development. Gross motor was a bit delayed and attributed to low muscle tone. She was late to pull the stand. And review of systems was really unremarkable. She had pretty extensive genetic testing before she came to see me. Everything was normal, and a lot of the genetic testing included skeletal dysplasias. She'd even had whole exome sequencing that did not reveal a pathogenic variant. Family height was right around 75th percentile and really also pretty unremarkable. And this is the growth chart for this child during infancy. And you can see that her length pretty much was just flatline. And her weight was going up, but not quite as much, not as dramatically falling below as the length was. And at her first visit, her length was more than 6 standard deviations below the mean. Her weight for length was at the 25th percentile, and head circumference and head growth had been okay. It was on the smaller side. She appeared really small and had what I describe as a doll-like face. She had not had any primary teeth erupt, and she had a slightly high arch to her palate. She'd had some prior endocrine testing done. Her IGF-1 level had been reported as normal, as had her TSH when she saw the first endocrinologist. She had had repeat testing that had also been interpreted for the thyroid as normal. And then at 10 months, she'd had an IGF-BP3 that was reported to be low. And when I saw her, my suspicion was quite high for growth hormone deficiency. And my next step in the evaluation was to actually do that stimulation test, even knowing that there are a lot of false positives. The stimulant I used, glucagon, you can also measure cortisol, which can be helpful not only for diagnosing if you have ACTH deficiency, but it's also helpful for kind of confirming that you have a good test going if it's a good response. And in this case, she had a beautiful cortisol rise, but her growth hormone stayed basically undetectable. And when I repeated, the IGF-1 level was kind of at the lower end, as was the IGF-BP3, and her total T4 was normal. So this looked very consistent with growth hormone deficiency. And in fact, she had an MRI that confirmed that she had a hypoplastic anterior pituitary gland. And after lots of counseling, I started growth hormone. And 2 months later, after growth hormone started, it had unmasked a TSH deficiency, and she was started on levothyroxine. And she ultimately had multiple pituitary hormone deficiencies due to a congenital malformation of the gland. And most of the time, there's no genetic cause for these conditions to occur that we know of. They're spontaneous, and you can see what a dramatic improvement in this child's length that she had once she started treatment. And at 7 years of age, she's caught up to within normal limits for the family and is growing very, very nicely. So it's one of the nice things with growth hormone. And I'll use the last few minutes to talk about growth hormone. So this is a picture of all the various pen devices that are out there. Growth hormone is a daily subcutaneous injection. There is on the market Skytrofa, which is this one on the lower left of the page, which is a weekly injection that was FDA approved last year. But the rest of them are all, and what we've been using primarily are daily subcutaneous injections. They all have different devices and cartridges, but they all do the same thing. Once we start it, no matter what the indication is, assuming the child's responding appropriately, not having side effects, usually it continues until they're at near adult heights, which for girls is a bone age of 14 and boys a bone age of 16. There are a lot of potential side effects out there. The two big ones that I worry about are pseudotumor cerebri, which kids are at higher risk for if they have true growth hormone deficiency, hypothyroidism, renal disease, obesity, or Turner syndrome. And then the other one I worry about is slip capital femoral epiphysis, which again is higher risk for those with the endocrinopathies, renal disease, and obesity. Any growth can worsen scoliosis. Growth hormone does cause insulin resistance. It doesn't cause frank diabetes, but it can increase insulin requirements when it's used in kids with diabetes. And then there are a few other considerations. There are a couple of reports out there about growth hormone causing cerebral vascular events. There are concerns about how data were collected for these studies, and the FDA has come out and said not to change prescribing practices based on the study. There's a more recent study that suggests cardiovascular events may be more common. The absolute risk is still really low, and it seems like there's higher risk with longer duration and higher doses. The FDA approved indications for treatment are growth hormone deficiency, idiopathic short stature, being born small for gestational age without adequate catch-up, Turner syndrome, and that SHOX deficiency, Prader-Willi, Noonan's, and chronic renal insufficiency. Idiopathic short stature is defined as a height more than 2 standard deviations below the mean. Bone age and growth patterns should also not suggest that the patient's likely to catch up on their own. And there must be no other cause known for the short stature or growth failure. The average benefits to treatment are about 2 inches over 4 years of therapy, but the response tends to be worse in those who have a low mid-parental target, so who have like the familial short stature. And treatment's really controversial. It's not approved in Europe. I think that it's beneficial in some cases, but I think in others, it's probably not so helpful. There are other conditions that are not proven to be benefited by growth hormone. And then there's some studies out there that suggest that there are other conditions that may benefit from it, but don't have FDA approval. And then I just really quickly just want to point out that achondroplasia, which does not respond to growth hormone well, does have a medication that's now FDA approved called voseritide. And I don't have time to go into that. And then I don't have time tonight to go into it, but there are agents out there that people use to delay bone maturation. I want to point out GnRH analogs, when used alone and only for the purposes of helping height, do not work in those who have normally timed puberty. And aromatase inhibitors are completely off-label for the use of benefiting adult height. It's not clear that they really do benefit adult height, and the recommendation is that they're only used in research settings. All right. So just to finish up the summary, hopefully everyone learned a little bit about how normal variants of growth, that genetics plays a big role, but also that there's a lot of genetics and a lot of variation, and that timing of puberty really does influence height velocity. For the abnormal variants, taking a thorough history and physical can be really helpful. When weight's impacted more, you want to think of systemic diseases and medications. When the weight percentiles are consistent and height's dropping, you want to think of the endocrinopathies. If growth appears normal, testing and treatment are not necessary. Growth hormone deficiency is not so common, and the stimulation tests have high false positive rates. And treatment should really be directed at the underlying condition. And growth hormone therapy for idiopathic short stature remains controversial. I just want to thank everyone. I know there are a few questions I'll stick around to answer. And just remind everyone that our next talk is with Dr. Markowitz, and that he'll be talking about lead poisoning and the shifting standards. And that's on Tuesday, April 11th. And his practice locations. All right, I know there are a few questions in the chat. I'll stick around to answer, and also feel free to take off your mutes, and I'm happy to answer too. Okay, the first question is, how long do you monitor a child? How long do I monitor a child you consider to have constitutional delay of growth and puberty before potentially doing testing? And have you ever used growth hormone in this setting? So I really try not to do anything with constitutional delay of growth and puberty. Because if there's no family history of delayed puberty, I do have a tendency to do the screening test for those kids, because we know that conditions like celiac disease, Crohn's, even hypothyroid, some of the endocrinopathies can be associated with delayed puberty. But once I know that they're otherwise healthy, if the height velocity is steady and appropriate and I'm watching puberty, I usually don't treat. And I really don't recommend growth hormone treatment for those kids. I did mention before, if it's really significantly delayed, so if they're 14 and boys, it usually is boys, so I'm defaulting to talking about boys. But if they're really delayed, then I will talk about testosterone, and I certainly have done it in a few select cases. Most kids, though, will spontaneously start puberty by 14. Any data on growth hormone, stem nevi growth causing neoplastic? Oh, So there are studies where they look at growth hormone and they count the number of nevi, and they're done on girls with Turner syndrome. And there's a suggestion that there are a few more nevi in the girls with Turner syndrome treated versus those who are not. It does not cause melanoma, and there really is no increased risk of malignancy. And I feel pretty confident about that one because there are a lot of databases of kids who've had cancers, and they've had radiation to the brain and subsequently been treated with growth hormone. And those kids are at pretty high risk for getting secondary malignancies, and there's no higher risk of secondary malignancy in the group treated with growth hormone in that situation. Okay. Sorry, typo. Any data on growth hormone, stem, and neoplastic change? So I hopefully I answered that question. Any other questions at all?
Molly, Peter Bellamarch here.
Hi.
That was great. I really enjoyed looking at the charts and having you walk us through that. Why does switching steroids work when you have adrenal suppression from steroids? Why is switching the brand from Flovent to another one? Why does that work?
I think it's just there's some systemic absorption, and kids metabolize the inhaled corticosteroids are just absorbed differently in different kids. So like, why does one kid on fluticasone do absolutely fine and probably grow better because they're not taking oral steroids 6 times a year versus the kid my patient who had the very extreme growth failure from fluticasone? He clearly just absorbed it better, or he didn't metabolize it as much, and it really impacted him. But he switched over to that newer one that I have to have it in front of me. It's like size, it's expensive. But it's supposed to be better for not having as much systemic absorption. I'm a little skeptical because I think it's not as widely used, and I think you have to have millions of people to be able to get like a few cases like this. So I'm not sure.
Sure.
Hi, can I ask a question?
Yeah, of course.
Yeah, so the lecture was beautiful. I think we need to hear it as many times as we can. Is it possible we're able to get a copy of this, or we can connect to in somewhere YouTube or something, or give it to the pediatrician whom I know who hasn't been able to attend today's lecture?
I don't know the answer to that, but I see Michael Dwyer is on and he's recording the meeting. So I'm assuming that it's saved somewhere. So hopefully that can be distributed. I'm sorry, I don't know the answer. So
If
Hello.
you can, it'll be very, I have a couple of other questions.
of course.
A 4-year-old child who stayed in the 1 percentile hasn't gone higher, and then had a growth hormone test done, and which was okay. Now, would you consider doing celiac disease testing on a younger child like 4-year-old?
Even at 4, it would be in my differential to think about. Sometimes when the kids are really young and they present with such significant short stature, I often find that my colleagues in genetics are helpful. Certainly if it's a girl, I would do a karyotype. I would be comfortable doing a karyotype for them myself. But beyond that, there are a lot of skeletal dysplasias that can cause short stature. Growth hormone doesn't work with a lot of the skeletal dysplasias, although it works with Turner syndrome, which is a part of the growth failure from that is skeletal. I mentioned that voseritide is being used for achondroplasia. There definitely are research studies using that drug as well as similar drugs that address some of the skeletal dysplasias and do benefit height velocities for those kids. So I think it's worth sending them to genetics, particularly if it's not explained and it seems out of the ordinary for the family.
Thank you.
May I ask a question?
Yeah, of course.
So this is maybe a little off topic, and I'm not even maybe a can of worms, but we had a couple of patients in my practice who basically what happened was they had sort of an early puberty without the growth velocity that should have come with it. And they got diagnosed late-ish and sent to endocrine late-ish. And the endocrinologist was quite peeved with us and said, you know, you should have caught this earlier. And so I wondered if you could talk a minute about how we should be watching for that growth velocity along with the puberty. Because the thing is, we were just looking at their growth chart, they looked okay. It was they weren't getting enough growth parallel to the pubertal development. Do you see?
Yes, I do. So I'm scrolling back in my slides here. So this is where I think the height velocity charts are really helpful. But also really important to do pubertal exams on kids, which I know is really uncomfortable. I do them constantly. I always feel uncomfortable. I try to, I joke about how uncomfortable we all are with the kids. I talk about like safe touches and, we go through all of that, but I think it's really important that you're always looking at testicular, and for boys, testicular volume changes are really the first thing that comes up. And really, it's going back to this height velocity chart. And when you have the kids who are the early bloomers tend to peak higher than the average bloomers and really should be following along this chart. I think you guys can see my arrow. Should be following along these charts. Girls you tend to have more girls who are early bloomers. I would also just argue, a few years back, I diagnosed 3 girls who came to me all for sort of that same scenario of they went through puberty. It seemed early normal, like, breast development at 8, 8.5, 9, but they just didn't have that growth spurt. And I diagnosed 3 kids with celiac disease within a year time. And I was like, I should make a case series of this. And I'm like, but they didn't complain of stomach aches a lot. I think celiac and Crohn's also, I've had kids with Crohn's that they don't present as classically as you expect them to with like the severe weight loss. And I recognize I am totally biased because I'm seeing all the kids who are coming, like who you guys are seeing, everyone who's healthy, and I'm getting the referrals for a lot is healthy variants and people who are nervous, but I definitely have a bias towards the pathology coming through my door. And so I don't think you can screen everyone in the population for celiac disease and inflammation. But I think if you're not seeing that good growth spurt, and particularly the early bloomers should have a robust growth spurt. If they're not having it, that certainly would be a red flag. I would argue really looking at the height velocity charts more than the that to me is the most important chart in my office than the standard charts.
So if we don't happen to have access to readily created height velocity chart in our EMR, what would be a quick and dirty way to kind of say, oh man, inches per year, whatever?
The CDC actually does have those charts. They have those charts out there. I think also my new division chief it came from Cerner. She used Cerner and she had longitudinal growth charts that she could pull up, she said, in that, and you could see the early bloomers and the late bloomer curve. It kind of like just puts them onto a standard curve, but it just gives you the early bloomer and late bloomer curves. It changes. So it depends on like what stage they're in. If they're mid-puberty, for a boy who is mid-puberty, you would expect, and they're an early bloomer, the 50th percentile peak rate of growth is over 4 inches a year. So if you're seeing someone who's, an early bloomer and he's only growing 2 inches a year, that should be a flag that something's up. but the 2 inches a year is all look totally normal on your regular chart, which I can see where that hits you. So does that answer?
Yes, very much. Thank you. Yeah.
When you start somebody on Lupron and growth hormone at the same time, I'm talking about a girl who was like around 12, now she's reaching 14, 15. So when do you decide to stop it? At what point? And what do you stop first and what do you stop second?
So I didn't have a lot of time to talk about Lupron tonight. Using Lupron in a girl at 12 years of age would be considered off-label. And the study, there is one study that was decent where they gave boys, and I want to emphasize boys because it was only boys with idiopathic short stature. They did growth hormone alone, they did growth hormone plus Lupron, and they did nothing. And when they added the growth hormone by itself really seemed to make the biggest difference, and roughly around 2 inches of benefit, which is similar to the other studies. The addition of Lupron added an extra 1/2 inch above the growth hormone group. This was a really small study, and so it's difficult to really, it's hard to say that it's definitely adding an extra 1/2 inch. I'm not aware of any studies in girls looking at that, although I know I just saw an abstract that has not been published yet where they did look at Lupron and growth hormone versus growth hormone in girls with idiopathic short stature. I am not a big fan, though, of treating with Lupron in kids with normally timed puberty. I don't feel like it leads to a significant height benefit. It takes away their growth spurt, and it alters like hormones that are naturally supposed to be there, both for like their bone health, their cardiovascular health, but also just their brain development and like their hormone, like just how they feel. And when you see kids who have been treated like that, often they will tell you that it did not feel good to them to have those hormones abruptly cut off. So it's not something that I routinely do. It's very select, and usually kids who, like when we do use Lupron off label like that, it's usually actually like a kid who's going for a bone marrow transplant, for example, and that we need to suppress the menses because we don't want them having bleeding when their platelets are low. We really do not treat off label so much for GnRH analogs.
Okay, thanks.
Any other questions?
The last question I have is, when should we start referring a patient as young as 2-year-old, 3-year-old who are failing into?
Whenever the concern comes up, I mean, like I said at the beginning, a lot of kids in infancy are going to have natural alterations in their height percentiles, and they're going to find that percentile channel that they're going to follow during childhood. Obviously, that very last patient I showed, one of my favorites, the 13.5-month-old, she had severe growth failure. Like she needed to be in the office. You know, she was getting evaluated from a very young age as an infant. So certainly if you have severe postnatal growth failure, I think that you should be in as soon as you're recognizing something that severe. But otherwise, I think that the referrals should really come when the concern arises, which can be at any age.
Okay, thanks a lot.
Okay. Any other questions? Thank you so much. So many of you stayed on so long. Thank you.
If you can get a tape of this lecture, it will be great.
Yes, I will follow up with
Please.
with Dr. Cabana's office about that. Thank you.
Thanks a lot.
Thank you, everyone.
Hi.
Oh, yes.
I just want to say the meeting is recorded,
Yeah.
and I'm going to collect that from Matthew Shore tomorrow morning.
Okay,
and we should be able to send it out to the participants that were here today, as well as the CME code. For those of you who joined, I'm going to send that first thing in the morning so you can get credit for this, for attending.
Great. So there will be linked to it, I guess, right?
thank you, Michael.
Thanks a lot. Beautiful.
Of course, there will be a link to the recording, and there will be a CME code, like a QR code and a passcode. You could use whichever one.
Thanks a lot.
Thank you. Thank you all.
Okay, bye. Thank you. Thanks.